We will go live. You are on live. Yeah. Dear urologists, greetings from Pure Urology. As you all know, Pure Urology is conducting regular surgical technique-based presentations for last 4-5 years from Preeti Urology and Kidney Hospitals. After some time, today, I am myself Dr. Chandra Mohan, who is the founder of Pure Urology. He is willing to give a talk on the supine PCNL and prone PCNL, in which conditions they are useful. Personally, I have 21 years of experience with PCNL. Initial 15 years I have done prone PCNL. I was very comfortable. As I developed more interest in RIRS, I thought supine PCNL is also useful. When I learned it. Now, recently, last 1 year, I am doing one supine, one prone, so that I can understand, is it necessary to learn both? Does it have any advantage if you do one or the over the other? So with my experience, whatever the knowledge I have gained, I wanted to explain both the procedures where in clinical conditions, how both can be approached. If you see here, first of all, I thank my technician for giving me opportunity to demonstrate on his body. Here in the supine position, when you see the abdomen, for anesthetist is comfortable. There is no doubt. For example, if you have a very obese patient, I mean, these are commonly applicable, not related to stone. If you have a very obese patient, if you have severe breathlessness, if patient is not fit for spinal anesthesia, you need to control the GA aspect, and high risk case is better managed in this position. That is no doubt about it. Second thing is undoubted fact is you want to have access from below by any chance, anything. But if you want to access from below, it is difficult in prone. There are some prone ECRS also, but it is difficult because legs are not separated in prone, but in supine it is separated. Otherwise, you have to separate. These 2 points undebatable that supine is good. Now in supine, the major disadvantage is you don't have a feeling of puncturing here. If you want to puncture, you have a feeling that viscera is here. It is true also. And you don't have a fixed landmarks. See, this is a rib cage, only fixed landmark. And if you come low down, you have iliac crest. After that, it is a free space. So to overcome that, people have made a posterior axillary line. Today, it's not that technique we are discussing. Different clinical scenarios we are discussing. Posterior axillary is variable because from here to here, if you are drawing a line, it can go like this, it can go like this, it can go like this. Some say in standing spine. So we made that if you take the hand like this and make a line, it will completely come. More than that, if you feel the rib, see it is the 12th rib tip. If you are in 12th rib, below that if you are there, it is safe. So it's usually horizontal puncture, horizontal to the table. And you are slightly away from the table like this so that your radiation is less. And if you want to be more space, we turn a little bit more like this. And then entire space is available like upper calyx, middle calyx, lower calyx. This is the primary about the supine PCNL. The predominant muscles that come is same like prone and supine. There is no difference. Horizontal puncture, even medially, you can go from here with this position. Nobody will go to paraspinal. Even in prone, you don't go. So paraspinal, you don't puncture. Maximum this level you will have. This level. So if you see in this position, if you are properly making the 12th rib tip, if you are popping the topmost point of the iliac crest, somewhere it's the posterior axillary line, then your puncture in supine PCNL will be somewhere here, in this point. 2 finger bits below, 2 finger bits below, and this is a safe point. Unlikely bowel will come. And in fact, bowel will move away, and in this position, theoretically, bowel will not come. And in supine, you will never do this type of puncture. You will do horizontal puncture. So bowel will not come in horizontal puncture. The major issue which I faced is, If you wanted to puncture the inferior calyx, the kidney is like this. Kidney is like this. So if you wanted to puncture the inferior calyx, you have to come anterior. You have to come anterior. If you want to puncture the posterior calyx, the superior calyx, horizontal puncture you can do. So primary limitation of supine PCNL is if lower calyx is facing like this, then it's not a good case for supine PCNL. If the upper calyx is facing like this, it's not. You have to do puncture sidewise. Then chances of hitting the calyx is less. Whereas in the middle calyx, anterior or posterior, whichever is there, supine PCNL is very good because you can go here, you can go here by changing the entry position. Whereas in prone, you can only go to the posterior calyx. You cannot go to the anterior calyx. It's not correct. Technically, it is not correct because parenchyma traveled will be more. So any middle calyx in this position, it is very good. Second thing is you will do horizontal puncture. Going into the upper calyx is easy in supine because it looks down. Whereas going into the lower calyx is a little difficult to look up. Whereas in prone PCNL, I will tell about the prone once the patient is changed. So to nutshell, when I was crazy proponent of the supine PCNL, the one I am facing repeated problem is lower pole calyx. If it is not a big stone, if it is a small stone, I'm not able to puncture it. Difficult. Ultrasound will add it. I'm not talking about the ultrasound guided. Middle calyx, excellent puncture through the cup of the calyx happens in supine. Upper calyx, fair enough, but if it is facing up, you cannot do it. Then people say upper and lower, if you cannot puncture, why supine PCNL? I will come about that. Now turn back, I will tell you. Turn back completely. See, when he turns back, see on the back, whatever the marking I have done is gone. Now this is the center of the spine. This is the paraspinal, and the rib is present here. Rib is present here. This is the iliac crest. All this space is available. But still we don't play all this space. We usually go from here. And the main point is my forceps will be like this. So chances of this iliac crest coming in my way is less unless I press and go to the upper calyx. So going from the lower calyx to upper calyx is difficult. Whereas lower calyx puncture is easy because even if it is calyx is like this, you will have a broad space to puncture. Whereas middle calyx problem is you can go only to posterior calyx. Whereas upper calyx, it will be supracostal. It's not horizontal puncture. It is like this. You have to come like this, like this. Then it will become 10th and 11th. A lot of people say there is no problem. Pleura is not a big major issue. No problem. And turning from the middle calyx to upper is the middle calyx to upper is difficult because you are looking up. Whereas middle calyx to lower is easy because you are looking down, because this is posterior. With this based, I wanted to discuss each clinical session on the board, if you permit. So we are thinking of a clinical scenario. This is the kidney and this is the pelvic stone, first clinical scenario. Will you do prone or supine? Will you do prone or supine? No difference. No difference. Obesity, breathlessness, that I am not going to dig again. If you wanted to go to the lower calyx, prone is better. If you wanted to go to the middle calyx, prone, supine, both are okay. If you want to go to the upper calyx, prone, supine, okay. But one thing is for sure, in supine PCNL, you need a lateral calyx. That lateral calyx will be 100% in the middle calyx. That lateral calyx may or may not be there here. So in RGP, if you see a lateral calyx in a pelvic stone, no problem. You can go for prone or supine. This is the first clinical condition. No difference. But if you wanted to go, if I wanted to go through middle calyx, I will go through supine because for patient, attendants, anesthetist, positioning is easy. It's a 1 minute position. Middle calyx, I will go and take out the stone. I'm not talking about the RIRS here. That's the clinical scenario 1. Now, clinical scenario 2 is if you have a stone in the inferior calyx, like this you have inferior calyx, like this you have inferior calyx. In this, there is tricky. I told you that in supine PCNL, you have to go anterior over the iliac crest. Whereas in prone, everybody likes to puncture lower calyx easily. That means alone stone without any stones, puncturing in prone is easy, easy, easy. There is no doubt about it. But if you wanted to do supine, you have to puncture like this. So if the stone is big, supine is okay. If the stone is small and calyx is like this, puncturing like this is difficult. So my conclusion is inferior calyx, large stone, supine prone no problem. Inferior calyx, medium sized stone without much lateral calyces, compound calyx, narrow calyx, prone is better. Now coming to the third clinical scenario, you have a case, you have a middle calycial stone, normal, middle calycial stone. So in this middle calycial stone, I personally feel if you don't know whether it is anterior or posterior, in supine, no problem. You just enter, go, feel the stone, or if it is posterior, go posterior. If it is anterior, go anterior with a fresh puncture. If you see cut like this, axial cut, axial. If the stone is here, you will go like this. If the stone is here, you will never go like this in supine. You will go like this only. But in prone, you have to travel like this. That's not correct. That's why middle calycial stone, big or small, lateral calyx will be there. Supine is very good. Coming to the fourth clinical scenario, you have a kidney like this. You have a stone, upper calycial stone. If it is facing up like this, again, if it is a big stone, you can attack from lateral, infracostal. But if it is a small stone and calyces is here in the top, then you cannot come with supine like this. So you have to come from prone. So upper, lower, single stones, prone is slightly advantage. Middle calycial stone single, supine has advantage. I mean, this is my opinion. Otherwise, you can see single stone if it is large. Anybody can do PCNL in any position. You go hit the stone or hit the calyx, get the urine and do it. But no much. So single stone is no definitive advantage of supine or prone. But prone slightly scores better. Now coming to the, we have finished the pelvic stone, we have finished the lower calycial stone, middle calycial stone, upper calycial stone. Now we are talking about the, if any questions are there, Kiran, you see. Not there. Huh? Not there. Not there. And if you have a multiple stone scenario, for example, you have a pelvic stone and you have inferior calycial stone. Same like inferior calycial stones principles it will apply. What happens? The lower calyx to pelvis is easy in prone. If this stone is big, if this stone is small, you can approach like this with supine. But in prone, if this is large and this is small, prone is better. Because you can puncture the stone without iliac crest factor. But one thing we have to remember is when you are baking the stone here, if they go to upper calyx, in supine, getting it back is easy, whereas in prone it may be difficult. That is the only factor. So, if inferior calycial stone and pelvic stone is present, slightly prone PCNL is better, especially if the calyx is narrow and if the stone in inferior calyx is medium. If it is large stones, both are okay. Again, same principle. Now coming to the pelvic stone with middle calycial stone, I will prefer supine PCNL because you can go anterior calyx, you can go posterior calyx. It will be parallel to the calyx like this. You come here. Access to the ureter, access to the upper pole, access to lower pole is very good with supine PCNL. Now, coming to the upper calycial stone and pelvic stone. If it is like this, then coming like this from the prone is easy. Going like this with supine is also okay. But if there is large stone here, going like this and doing nobody likes. Nobody likes. That's why you come from here and then finish by prone PCNL. Now coming to the, so we have discussed two stones. Now we will discuss with three stones. This is important. Why? Because, for example, if you have a kidney like this, you have a stone like this, you have a small kidney stone, you have a small stone, you have a small stone here, or two stones. Then the role of RIRS will come. You cannot ignore it. You cannot say that why RIRS, I will puncture this, I will puncture that, I will puncture this. You can puncture any number of times if you are skilled, that is not a problem. But for a 1 centimeter stone, 1 centimeter stone, 1 centimeter stone, three punctures you cannot do. What I do is, I will nicely select supine PCNL. I will go here, 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 here. If I take out everything, great. And possibility is good. With flexible nephroscope, it is good. With rigid nephroscope, it is good. And I am generally in Chinese technique, middle calyx is highly better, and perfect anterior posterior calyx can occur in supine PCNL. At the same time, if the flexible scope, nowadays, people can argue that you have to put the access sheet and for that ureter should be dilated. Not necessary. Now scope is 6.3 friend. You thread it, you go there, pluck it out and give to this person. This pluck out, you come here and finish it off. So if multiple stones small are there and if pelvic stone large is there, then supine PCNL and DCRS will come a major role. That is the reason why you have to learn the supine PCNL. Now coming to the large stones. For example, you have one stone here, one stone here, one stone here, one stone here. What will you do? See here, you cannot say that I will do ECRS only, because for ECRS it takes time. You have to do two punctures. Because three large stones you cannot remove with RIRS and then combine with PCL, it will be cumbersome. Finish with PCL only. How will you finish? Normally, people say if you come from here in prone PCL, you hit it, you turn like this, maximum you may not remove it, you do another puncture. That is the most commonly practiced clinical scenario in prone PCL. Same thing if you wanted to do supine, how will you do it? I will do through middle calyceal puncture. I will remove this. Usually I can turn easily here. This is doubtful. In that case, I will puncture supine again here. That is the way. That means two puncture, two dilatations. Of course, it depends on the PCS. It depends on various factors. But grossly, I am telling about this. So, if multiple stones small are there, supine ECRS is a major role. If multiple stones large are there and this thing, prone is better. Now, one of the last criteria. Now, you see, the kidney is like this. You have a large stone, stag arm. These are all stone. Lot of people say that I have removed this stone. And in fact, to be honest, this type of large stones, easy stones, not very difficult. Only thing is that they take time. They bleed sometimes. Otherwise, puncturing, there is no technique here. Because such a big stone on the lateral aspect, you puncture here, you puncture here, you will space, you remove this, you get space, you remove this, you remove this, you remove this, you remove this, you remove this. This much anybody can remove from it. This much anybody can. For superior this much. All other two cases, mostly they will come in one puncture. In fact, these are the stone. In one puncture, one dilatation, you can finish also. These are not very difficult stones. So supine prone does it. But I prefer prone in this case because you look down in breaking in prone. So that fat you can break and take out the fragment. Whereas supine, you will look horizontally. The fragments come out, but bleeding appears more. And if you make fragment, they will come out, but somebody has to flush more. And to break like this, with the mission, it is difficult. To break like this, it is easy. That is the one factor. Now coming to the stag arm stone, true stag arm. True stag arm, now it will be like a stags. We have to see like stags. See, this is small infundibulum, then small infundibulum, then small infundibulum, then small infundibulum, and then go like this. The stone is here, the stone is here, here the stone, here the stone, here the stone, everything stone is there. This is the most difficult case. Here is the one where your brain has to assess the CT anatomy, RGP anatomy. You have to be really carefully calculate, say the patient that stone free rate 100% may not be acceptable. In that case, First, choose whichever is accessible to the pelvic stone. Aim is to remove the pelvic stone so that kidney urine can come down and remove as much as possible with this. Then what is left behind? Like this, like this, like this, along with this. So here you cannot say supine or prone which is good. You have to calculate your own experience, your own number of punctures, hemoglobin status, the obesity, all these things you have to calculate. You can do another one or two punctures remove. After that you can do RIRS with PCN tube, or you can do supine PCNL with combined RIRS, but it will take time. Generally more than 1 to 1.5 or 2 hours it is better to avoid, because unknowingly blood loss will be there. These are the most difficult cases where I cannot say at least that, in fact, I am seeing less these number of cases. In the cities, people are getting ultrasound before birth and coming at 3 months age to me for RIRS. So these stones are less seen for us. But if it is seen, it is a true challenge, but multiple settings are necessary. You cannot score for prone or supine PCNL. Now coming to the upper ureteric stone and PCNL. Wherever stone, manlo wherever stone, and there is an upper ureteric stone. And in this case, what the prone PCNL surgeon does is they go URSL and they push the stone inside and do prone PCNL. But I disagree here. If you have access sheath, flexible scope, you can finish the ureteric stone. Even if you push also, your access sheath will be below the PUJ, it won't come back. But in prone, by chance, if it comes back to mid ureter, what will you do? Flexible ureteroscope, flexible nephroscope, it's not easy. If your rigid scope is not reaching, you are 1 centimeter short of, you cannot do anything from below. That below when you want, you go for supine PCL. Below when you want. So any ureteric stones, especially mid-ureter 2-3 stones like that are present, I prefer supine PCL. Now coming to the kidney ureter, and there is a stent. You have a stone here, you have stone here, stone here, stone here, you have stone here. This is, I feel, very suitable for supine PCL. You break this stone in cystototic position. You break these stones into URSL. Go as high as possible. Don't take stress. Now you same position other surgeon will break, and either he will pull or he will pull, no problem. And he can check from below. They can check from above. Complete clearance is assured, and no ginger of again turning, again doing URSL, again off stent removal. This is an absolute advantage for supine PCNL in the absolute advantage of the supine PCNL in the retained digestate. Now, when it comes to the single stone upper ureteric stone, some people try URSL. If it fails directly, they will go to prone PCNL. But I feel you even if it is not coming, my gut feeling is that from middle calyx to the ureter, supine PCNL you can reach lowest level. From middle calyx, supine PCNL you can reach up to here. Whereas in prone PCNL, from upper calyx you can reach here. But upper calyx we don't like. So mid-ureteric stone, you can jolly well come with the supine PCNL. And of course, you will have something from below also to help. So dear friends, to conclude, what my idea of this talk is, I have so many RGPs. For example, yesterday I was doing a case. What is the case? This is the kidney. This is a big stone. I am sharing this case live. There are small stones here. And when contrast is injected, it is not going here. It is going here only. What will you do? If you go through this calyx, you may not remove it. So what I have done, I have done prone. I have aimed this one of these stone. This aiming cannot be done in supine PCNL. Very difficult. If the contrast is not there, if the stones are small, you cannot aim in supine PCNL. Lower calyx, you have to be careful in supine PCNL. It's not easy. Length of the needle tract will be long. So large stone, fine. Medium and small stones, you cannot do that. So that is the end of my talk. So to conclude, in nutshell, what I wanted to say, I will take the questions at the end, no problem. In nutshell, what I wanted to say is, if the patient is very obese, very short of breathlessness, and patient anesthetist says that supine is better, you have advantage of supine in any case. If you have any RIRS component in your surgery, supine is better. If you have ECRS component, supine is better. If you have a bladder stone, ureteric stone, multiple ureteric stone, supine is better. If you wanted to go through the middle calyx and can do many things, supine is better. If you have a large stone in the lower or upper calyx, supine is okay. In the rest of the cases, like for example, medium-sized stones, upper lower facing calyces, prone is better. But honestly, the dilatation is easy in prone. The breaking is easy in stone. In prone, you will be slightly nearer to the C-arm. I don't know how much C-arm will cause damage, but in supine, definitely C-arm related radiation is less because you are slightly away. In supine PCL, it's a horizontal puncture. So dilatation while doing, you have to put your hand, especially in children. Otherwise, it can go thirst. Whereas in prone, you are through gravity, so it will go nicely and you can stop wherever you want. And in supine, because of the water flow, fragments will come out by easily themselves. Whereas in prone, fragments will be seen nicely because water will be pooling and you can take one stone out. In supine, when you pass a guide wire, unless it goes into ureter, guide wire slippage is more common because it's horizontal. Terumo guide wire slips a lot in supine. Whereas in prone, usually you are like vertical, you are like 45 degrees. You will be really comfortable with the guide wire, Terumo also. So these are my opinions. With this, Muninder, any questions, please?
Sir, first question. What kind of stone that prone PCNL is not totally recommended?
See, this is actually a tricky question. It is to poke that why should we do supine? Prone can do anything. I agree. I totally agree, except I told you clearly, if you have a retained stent, if you have a anterior middle calyceal stone, anterior middle calyceal stone medially, you see Munindra, sir. This is the kidney. There is a stone here medially. Yes. Medially. Here. Yes. Here. And that in axial cut, if you see like this is anterior, this is posterior. If it is like this, supine nicely you can finish. Whereas prone, if you come like this, you can hit any artery here. There is only one clinical condition, medial anterior located stone, reasonably good sized stone. Laterally, if you come, you can finish safely because your needle will never reach the infundibulum. In supine PCNL, because you attack laterally in the C-arm, you can never reach this and get the, you will never go here. Whereas in prone, you are coming from apic angle, you can land up here, you can land up here, you can land up here, still you can get urine. That's why in supine, either you fail or you properly go through the calyx. Whereas in prone, you can go medially and damage the infundibulum. In supine, you don't see infundibulum because you will see only calyx. That's why puncture accuracy is more, and technically sometimes it may not happen if the calyx is not big. You got the point, what I'm telling? Prone PCNL, you can do anything, no doubt about it. But retained stent, multiple ureteric stones, middle calyceal stone, medial large, supine has absolute advantage.
One more question, sir. Large stone in the proximal ureter, which is small stone in the lower calyx.
Yeah.
Prone or supine?
Yeah. See, when you don't have contrast, large stone you are saying, you inject RGP, don't think supine or prone. You inject the contrast. If the contrast goes into the kidney, you decide the anatomy and then go middle or upper calyx in prone, no problem. But what I will do is, I will go through supine, I will try to push from below the stone or break the stone. I will try to put a flexible scope by the side of the stone and inject some contrast, making it not blind. I will go through the middle calyx. As I told, I can easily reach the upper uterine stone more easily with supine with my experience, and lower calyceal stone small anyway will come from the supine PCNL. So I will remove it and I can pass something stent from below, I can pass guide wire from below, I can pass flexible scope from below, anything I can pass from below. So I have an access from both the sides. I will take care of the ureteric component stone.
Third question, sir. When do you take the help of ultrasound in supine PCNL apart from mal-rotated kidney?
Ultrasound in the Western countries, it is mandated. This question doesn't arise because PCNL is a blind procedure. You see CT, you see IVP, you think in your brain, you go accordingly. But ultrasound, virtual reality. You see the spleen, you see the kidney, anybody, all of us know it. We always have ultrasound in the theater. We see the column, we go accordingly. But you are asking a question, when will you use ultrasound in supine patient other than mal rotated kidney? I don't need, in one condition only I need retrorenal column. If retrorenal column is there, I want ultrasound for the entry level. Otherwise, I will puncture the column. And in fact, if retrorenal column is there, if you have any window, that window you can assess in the ultrasound very well. If you don't have that window, you can injure the column. Otherwise, ultrasound has no role. Another role ultrasound has. You tried so many times in one direction, two direction, you are not getting clue. Then you go to ultrasound, it will tell where is the calyx, so that you can try from there. It happens in PCNL. Sometimes everything is good, but water will not come or guide wire will not go. Then ultrasound is useful. That is common for prone or supine.
Next question, sir.
Yeah.
What if upper ureter stone with the tortuous ureter and URS is not possible to reach this?
Yeah, this is very important question. You have upper uterine stone, you are good in PCNL, you are good in URSL, you are good in RIRS, but it's a frustrating situation. However good you are, guide wire doesn't go. However good you are, ureteroscope doesn't go. If you wanted to puncture for small stone, you feel bad. You want to do something, try below only. What will you try? Merge maneuver. You push the abdominal wall, it may straighten up. What is the next? Flexible ureteroscope directly into the area. What it will do? Unfold the ureter. But scope damage chances are very high. What you will do if after that also not there? Same question you asked. Large stone, but here it is small stone. How to puncture the kidney blindly? Is it which is safe to puncture the kidney blindly, supine or prone? Prone, because prone definitive criteria are there. For example, you are like this prone, you have a rib here. People say that below the rib, if you make a 45-degree angle with a spinal needle, you can get that urine out of it. But in supine, it is not easy without ultrasound. So crux is ultrasound. Crux is flexible ureteroscopy. Crux is your experience in puncturing blind. I don't puncture blind now. I have ultrasound. Previously, I used to puncture 2-3 times, urine comes, then I inject contrast. Nicely, I will see from where upper uterine stone can be removed. Usually in prone, better to come from middle or upper. But I am telling you in supine, from the lower calyx also. This is the lower calyx. This is the stone. This movement is easy in supine because it's a horizontal puncture. You rotate horizontally up and down. Whereas in prone, you go down first and then up, then into ureter. It may have torque on the infundibulum, but supine it is slightly less. Again, it depends on various factors. Gross criteria I am telling. Next question.
How to get efficient stone guided puncture in either supine or prone PCNL?
Yeah, this is also important question. See, stone guided puncture, one important thing is, for example, you have like this, there is a big stone here, you don't have any access to the kidney, you have a stone here. Now you wanted to do this stone guided puncture. It is in the periphery. Stone guided puncture cannot be done in pelvis. Stone guided puncture you have to do only in pelvis. Now if you wanted to puncture this, you should aim this half of the stone. This half. Whether prone or you have to go and touch and feel it. 10 times, 20 times you try, but you have to feel the gritty sensation, and after that you have to stop. And second point, to reach that stone, you should go in a straight line. Why? Because guide wire may not coil properly. So if you reach up or down, like a lot of the people turn this way, then guide wire will be there. But after that, Alken rod dilators will not go easily. That is the problem. Single step dilatation becomes difficult. So straight hit the stone from the half lateral aspect. Never hit here. Your needle and C-arm should never cross this line. Normally, they say that you never cross the infundibulum. Here, because it's blind, don't cross this line. In the stone also. In the stone also. However small or big it is. That needs more precision.
Next question, sir. Upper calyx stone, which is better, prone or supine? And what are the tips in supine for supracostal funds?
Yeah. So it's a good question again. If you have a calyceal kidney stone like this, okay, and you are having upper calyx like this, or sometimes upper calyx like this, sometimes upper calyx like this, sometimes sharp upper calyx like this, but usually it is compound. It will be like this. This is the commonest. Here you can puncture, here you can puncture, here you can puncture here. What happens in prone PCNL is you come in this direction, in this. Prone, supine, it will not happen. You will come in this direction only. You can't puncture. Even if you puncture, you have to come like this. You will never go to the vessels here, but you will come like this. So, prone, you will come like this. Prone, you will come like this. Supine, you will come like this. This is more safer. If the stone is large, if lateral calyx is present, there is no problem in supine. There is no problem at all. You turn 15-20 degrees little that side. Horizontal puncture, always you give access. Straight you go. The tip he asked is, for example, this is upper calyx. You have a stone here anteriorly. You have a calyx posteriorly. You came like this, horizontally. You did not hit the stone. Then check in the C-arm. It is more anterior. Don't try like this. That is the only tip. You go little anterior and finish it off. This anterior and posterior are easily seen in supine. Don't worry that it is not seen in the rib. And it is slightly infracostal than prone. Slightly less, lower in the prone. Slightly lower in the prone. Sorry, like slightly lower in the supine. Because it's a horizontal pulse. You need not travel. You need not travel like this. If you want to travel like this, your ribs will be high. You will be traveling like this. 12, you can finish. 12 or above the 12.
Next question, sir.
Yeah.
Why in supine PCNL the retrorenal colon is lower?
No, actually, the study says that this is a theory. We should not apply theory too much. 1% in prone, 10% in supine. Logically, what happens? See, this is the axial cut of the stone. If the colon is here, like this, if you turn this patient like this, colon may go here and attachment will be there only. Colon may go here. So nobody will puncture in supine like this. They will always puncture. If the colon is here, anyway it will hit. If the colon is here, anyway it will hit. But normally, definition of the normally in the kidney it is like this. If it is pelvis like this, it is stone like this. Axial cut at this level is very important. If that level kidney, axial cut with pelvis here, if the colon is present up to here, it is okay. If it is coming here, this part will become dangerous. So, at any cost, axial cut be seen, but in the lower part of the kidney, colon will come more posterior. That is not the area you puncture. You will be puncturing the skin there. In the middle and just lower middle part, in these regions, in these cuts, the colon should not be there. In this cut, if it is there, also no problem, because at skin level, you will enter there, and by the time you reach the kidney, you will reach to the mid level. But generally, up to the lower calyx, up to the lower calyx, up to the lower calyx, axial cuts. If you see here, if you see here, if you see here, if you see here, anywhere in this thing, colon should be like this. Colon should be like this. Colon should be. If it comes into this region, you are at risk, both prone and supine.
Sir, what is your comment on blood loss in same size staghorn stone in supine versus prone?
Honestly, supine blood loss slightly more because water you need more and you will be washing water more. I have a feeling that redness will be more in the supine because water will wash off immediately. So slightly, I have a feeling that supine I lose blood a little more. In staghorn.
Yes. One more question, sir. Between flexible cystoscope and flexible QRS, which one is preferred for treating residual stone after PCNL?
That is also very important question. If you are going like this, if you have a stone here small, you come through this, and this is the calyx. Flexible cystoscope going here and bringing out is difficult than flexible URSL. This is a very important question because for RARS, you need a long tube to stabilize. Whereas in flexible nephroscope, nowadays biorad no conflicts of interest, it is slightly slender, and it goes to the upper calyx. To put the basket, to put the laser fiber, to get oriented, water will be leaking. In prone or supine, water will leak. If it is just mobile stone, get out is okay. But if it is impacted stone, RARS, ECRS, supine position, oh, nicely you can. That's why RARS has become famous, everybody is using. Flexible nephroscopy, less commonly used. But nowadays, because of the tender scopes, one stone floating, you can bring it back. But not using laser for a large stone. I tried, somehow I have not seen in conferences also flexible nephroscope lasing many often. They do another puncture and fatafat they will remove it. So I feel flexible RARS is much better than flexible nephroscopy.
Tips to puncture hypermobile kidney in supine patient.
Yeah, supine PCNL hypermobile kidney is minus because when you see on the abdomen, if you are coming like this, the anterior abdominal wall is free and it will freely move. Whereas when you turn back and sleep, this part will be fixed. So prone, nothing will move. Everything is fixed. In supine, everything will move. Your colon will move, skin will move, rectus sheath will move, and the kidney also moves. So you have to put your hand, then radiation will come. Then people prone say that what is this hand? We never put hand. That is true. Especially in children, dilatation of supine PCNL is really tricky. Really because rectus sheath will be very elastic, very tough. And you have to really dilate slowly. You have to be really slow. Whereas in prone, you go down, abdomen speaks, there is no problem. So putting your hand is the only answer. Gentle rotatory movement is the answer.
Any role of flexible nephroscope in PCNL, sir?
Flexible nephroscope role is there. I told you already that if the flexible nephroscope can be easily passed in a dilated system, okay. But an acute system, the flexible nephroscope tip, whichever 7 centimeter or 8 centimeter, should be in the PCS. For example, it is like this. It is like this. Your ampla sheath is there. Flexible nephroscope here it is partly there. Here it is partly there. Once you go, then only it can go. That means this much length should be inside kidney. If the stone is here, you cannot do it. You can't flex like this. It is here or here, it's okay. Or from lower calyx to upper is good. Middle calyx to parallel middle calyx, flexible nephroscope is also difficult, whereas RARS, ECRS is easy. ECRS, Munindar, you be here. One more stone is here. Even by the side of the amplage, if you have anything, flexible ureteroscope can pick up. Yeah. Very big advantage. That's all.
Last question, sir.
Yeah.
Sometimes liver will be covering most of the right kidney, sir. Then which approach is safe?
See, that is also a common scenario. In the CT, if you feel that the liver is like this and kidney is like this, only lower pole calyx you have to approach. So that is a disadvantage. In that case, supine PCNL is better because RRS can do something missed stones. In horizontal puncture, for example, in prone, always you come like this. Horizontal puncture, still this part also you can avoid the liver. So slightly supine has advantage if the liver is covering because horizontal puncture there is no obliquity. Posteriorly you can go, avoid liver, and then horizontally come into the kidney. That window you have to read in the CT. That is it. I have around 20 cases, but today is not the time. It is regularly I am posting. Yesterday I have done one inferior calcium stone that I am posting live video how we punctured as a prone PCNL. So my message is that lot of people argue in WhatsApp groups or this thing that I never did supine, I never did prone. Why should we learn so many positions? It's crazy. It is to attract. You should not talk like that. We have to be scientific. There are papers on that, there are papers. More papers have come on supine now because of the ECIs. So sometimes in a fourth Saturday workshop, when I am puncturing, I will show the needle where it is coming from. For example, two cases parallel are there like this, and one has stone. In prone, it is very difficult to differentiate. In supine, you put a flexible scope, you pass here, you pass. If it is needle is coming here, don't dilate. Again, go here, get the guide wire here. But people say all this is nonsense. Two surgeons are required, two urologists, two flexible scope. Why all this? I can puncture any stone. So, okay, if you are good, fine. But there is nothing wrong in learning RIRS, supine PCNL, prone PCNL. You apply your own this thing if you are good. Now I am doing again prone PCNL inferior caliber is difficult. I judge and finish very fast. I am comfortable. I am not denying that. But it's all your experience. There is nobody can say that this is not at all necessary. I never did it. No, that you should not say. So to conclude, because the time is already 50 minutes, dear friends, any new technology, new technique, don't throw away. If it is financially viable, if it is a technique, not technology, if it is technique, learn better and practice whatever you are comfortable. See how the other people are doing and try to learn. That is the aim of pure urology, because we are surgeons. We need to do surgery with background of science. Science anyway says that supine PCNL has come way before by Valdivia, sir. See, in 1980s, when we were born, nearly we were born. So how can you say that it's published? Or somehow or the other reason, because RIRS is not there, it is not famous. Now it is coming. So you have to outweigh the advantage and disadvantage and give the best benefit to the patient. Now fan sheath has come. Some people say that RIRS ureter may damage. Yes, it can damage. Stent it and do it, and gently you do it, combine with the PCNL. A large stone volume, no doubt PCNL is good. How can we say that RIRS is good? Large stone volume, stag can we do RIRS? Even after 10 years, I don't think stag can be done with RIRS. That is the way. So I once again thank all the viewers for these questions, and also thank Pure Urology various contributions from the members. We wish we will continue this online education and make it useful for the juniors and also through the juniors and seniors to the patients. Thank you once again.